Hi, good evening, all. Welcome to this recall session on INICET May 2024 exam, which was held on this Sunday. What we'll do in this session is we'll try to answer and discuss the anatomy questions that were asked in May 2024 INICET. Just let me know if I'm audible and the screen is visible. Hi, sir. Can you confirm if I'm audible and the screen is visible? Yep. So let's get started with the anatomy recall session. There were about 10 to 12 questions that were there from anatomy, and couple of them were integrated with surgery. Some of them were integrated with ENT and then orthopedics, radiology, even OBG. Fine. So we will try to discuss the core anatomy topics to begin with, and I will tell you wherever it comes where these will be discussed further. Now let's begin with the first question. Most of the questions in this session were from head and neck region, and couple of questions from the neuroanatomy section. First, let's try to discuss all the questions that were asked from the head and neck topics. The first question was from the constrictors of the pharynx. The question was an image-based question, as most of you have recalled it. So the question was, which structures pass through the marked area in the image? Okay, so this area was marked among the constrictors, and the options given were glossopharyngeal nerve and the stylopharyngeus muscle, then the recurrent laryngeal nerve and inferior laryngeal vessels, the internal laryngeal nerve and superior laryngeal vessels, the auditory tube, and the muscle levator villei palatini. Right now, which of this is the correct option? So in order to solve this question, you should have the knowledge of what structures pass between the constrictors of pharynx. Fine. So let's try to discuss that, and we'll come back to this question. So when we talk about constrictors of the pharynx, the first thing is to identify the three constrictors. We know that the muscles of the pharynx are arranged as constrictors and longitudinal muscles. Out of the three constrictor we have, this is the superior constrictor muscle. Okay, so we have the superior constrictor, then here we have the middle constrictor, right? And then we have the inferior constrictor. So the first thing is, how do we identify these as constrictor muscles? Now take a look at this raphe, the pterygomandibular raphe, which is the primary origin of the superior constrictor muscle. So this is your superior constrictor. Now, the middle constrictor muscle takes its origin from this bone. Now, what is this bone? This is the hyoid, right? So, majority of the fibers of middle constrictor arises from the hyoid. So, this is your middle constrictor. Then, the inferior constrictor has a thyropharyngeus part. Then, it has a cricopharyngeus part. So, this is the inferior constrictor. So, the first thing is to identify these constrictor muscles. Once you identify the constrictor muscles, the next thing is to recall what are the structures passing between these constrictors. First, if we talk about the space between the base of the skull and the superior constrictor, remember this is called as the sinus of Morgagni, right? So this is called as sinus of Morgagni. And what structures actually pass through this? Remember, the first structure is the levator villei palatini. This is one of the muscle of your soft palate. Now, where does it take its origin from? It takes its origin from the auditory tube or the pharyngotympanic tube. Then you have the ascending pharyngeal artery. And the fourth one is also an artery which comes from ascending pharyngeal artery. This is the palatine branch of ascending pharyngeal artery. So these are the four structures which pass above the superior constrictor and between the base of the skull within the sinus of Morgagni. The next important space is the space between, what do we have here? The superior constrictor muscle and then the middle constrictor. So this space allows for the passage of two important structures. One is the stylopharyngeus muscle. So stylopharyngeus muscle, and along with this it has its nerve supply. Now remember, stylopharyngeus is the only muscle that is derived from the third pharyngeal arch, and it is supplied by the nerve of the third pharyngeal arch. And what is the nerve of the third pharyngeal arch? It is the ninth cranial nerve or the glossopharyngeal nerve, right? So these are the two structures which pass in the space between the superior constrictor and the middle constrictor. Then comes the space between the middle constrictor and the inferior constrictor. So what passes through here? Remember, here we have the superior laryngeal vessels and internal laryngeal nerve. Remember, internal laryngeal nerve is the chief sensory nerve to the larynx above the level of the vocal folds, right? Then the last structures pass beneath the inferior constrictor, that is cricopharyngeus. And what are these structures? Remember, these structures include the recurrent laryngeal nerve, and then we have the inferior laryngeal vessels. Okay, so this is how the structures are arranged and pass between different constrictors. Remember, the space between the thyropharyngeus and cricopharyngeus also has a clinical significance. Now, can you recall what is the clinical significance? This is also called as what? This is called as the Killian's dehiscence, right? Now, whenever there is neuromuscular incoordination of thyropharyngeus and cricopharyngeus, this will result in Zenker's diverticulum. Right? So this is regarding the structures. So what was the image or what was the structure that was marked? If you take a look at it, the space between superior constrictor and middle constrictor was marked. So what are the structures passing between the two? We have the stylopharyngeus muscle and the glossopharyngeal nerve. Okay. So what is the correct option here? The correct option here is the glossopharyngeal nerve and stylopharyngeus muscle. Right? So these are the structures passing between the superior constrictor above and the middle constrictor below. So this was regarding the constrictors of pharynx. Let's move on to the next question. Now the next question from the head and neck was from extraocular muscles. Now some of you have said that there was a question which asked which of the following is not a function of superior oblique. Superior oblique, as we know, is one of the extraocular muscle, voluntary extraocular muscle, and which of the following is not a function of superior oblique. So most of the time when we see the topics that we know, we get excited and we might miss these keywords. So here it is asking about which of the following is not a function of superior oblique. So let's try to recall the actions of extraocular muscles by drawing the Starling's diagram. Okay, so what we'll do is first we'll draw the outline of the eyeball. Okay, so let's imagine we have the eyeball here. So just for the sake of understanding, let's say here we have the nose. So this is the right eyeball that we are talking. So let's imagine we have the pupil and we have the cornea, right? Now let's describe the action of each of the muscle. First, let's talk about the actions produced by the medial rectus and the lateral rectus. So here we have the medial rectus and here we have the lateral rectus. Okay. So what is the action brought about by medial rectus and lateral rectus? Medial rectus moves the eyeball towards the nose, which is adduction. The lateral rectus moves the eyeball away from the nose and this becomes abduction. These are the two actions of medial rectus and lateral rectus. Okay. Now once we have learnt about medial rectus and lateral rectus, let's talk about the superior and inferior rectus. So let's imagine this is the superior rectus. So what is the action of superior rectus? Superior rectus elevates the eyeball. But apart from this action, it also has the following actions. What are they? Remember, this can bring about adduction of the eyeball. Okay. Then it can also bring about intorsion. Now what do you mean by intorsion? When the eyeball rotates towards the tip of the nose. Okay. So actions of superior rectus include what? Elevation, then adduction, and then intorsion. Similarly, when we talk about the inferior rectus primary action is this brings about depression of the eyeball. Apart from this, this can also adduct the eye and this can rotate the eyeball outwards, that is away from the tip of the nose. So this becomes extorsion. So what are the actions of inferior rectus? Inferior rectus can bring about depression, then it can bring about adduction, and then it can bring about what? Extorsion. The actions of oblique are quite opposite to that of the recti. So we have two obliques, right? Now these two obliques, remember, have exact opposite action. So what does inferior oblique do? Inferior oblique will cause elevation of the eyeball, and this is directly related to the attachment. Okay, so inferior oblique brings about elevation of the eyeball, then it causes, what is this action? This is adduction, then it moves the eyeball away from the nose. So this is extorsion. So this can bring about elevation, abduction and extortion. Right. Now let's talk about the superior oblique. The superior oblique brings about what? This brings about depression of the eyeball. Right. So this is exactly opposite as to the action of the inferior oblique muscle. Right. Now it can bring about abduction. Right. And apart from this, this can also bring about intorsion. So superior oblique, what are the actions? It can bring about depression of the eyeball, then it can bring about abduction, and then what is the action it can bring about? This can bring about the intorsion. Right. Now let's go back and try to analyze which of this is the correct option. So what are the actions brought about by superior oblique? Superior oblique brings about depression. Superior oblique brings about intorsion, as we have learnt. Superior oblique also brings about abduction. But what superior oblique cannot do is, it cannot bring about adduction. This is the function of the recti alone, not the obliques. Obliques can bring about abduction, but not adduction. Fine. So this is how you solve this question. Okay. And believe extraocular muscle is one of the favorite topic of your examiners. Let it be a university exam or an entrance exam. This is one of the favorite topic of examiners, right? The nerve supply of the extraocular muscles, which can be remembered by the famous mnemonic LR6 is of 4 and rest by 3. And then the actions. And the actions cannot be mugged up. Okay, so this is a simple diagram which will help you to recall and remember the actions of all extraocular muscles. So this is one diagram that you should learn thoroughly. Right. Now hope this concept is clear. So what is the correct option here? The correct option here is the superior oblique cannot bring about adduction. Fine. So this is regarding the actions of superior oblique. So this was one of the questions asked from the head and neck region. Now apart from these two questions, the next question was from the topic of head and neck again, and now this was from the oculomotor nerve. Now, some of you have recalled this question as, which of the following is again not seen in the third cranial nerve palsy? The third cranial nerve palsy is the oculomotor nerve palsy, and here are the options. In order to solve this question, what we must know is the actions of oculomotor nerve, the functions of the oculomotor nerve. So what we'll do is, let's try to recall what are the functions of the oculomotor nerve, right? Now, oculomotor nerve supplies your extraocular muscles. What are the muscles it supplies except the superior oblique and lateral rectus? All other extraocular muscles are supplied by oculomotor nerve. Okay, so oculomotor nerve supplies what? Medial rectus, superior rectus, inferior rectus, then inferior oblique and levator palpebrae superioris. Right? So these are the voluntary extraocular muscles innervated by oculomotor nerve. Then, if you remember, the Edinger-Westphal nucleus, okay? The Edinger-Westphal nucleus, which is associated with the oculomotor nerve, innervates the sphincter pupillae. Okay? This innervates sphincter pupillae. Now, what is the action of sphincter pupillae? Sphincter pupillae brings about constriction of the pupil, right? So, this brings about constriction of pupil. Then, the other important function of oculomotor nerve is it also supplies the superior tarsal muscle. Okay, the superior tarsal muscle. Along with levator palpebrae superioris, it also supplies the superior tarsal muscle, right? Now, if the oculomotor nerve is paralyzed, the medial rectus is paralyzed, and this will result in failure of adduction of the eyeball. If superior rectus is involved, failure of the elevation of the eyeball, adduction of the eyeball, and intorsion of the eyeball. So what we are looking here is, we are looking at these two important muscles, okay? Levator palpebrae superioris and superior tarsal muscle. If fiber supplying this muscle or these two muscles are damaged, it will result in drooping of the upper eyelid. Okay. Now, what is drooping of the upper eyelid called as? It is called as ptosis. So, if you know the functions of the oculomotor nerve, you can easily answer this question, right? So, let's go back and try to solve this question now. If the oculomotor nerve is paralyzed, can it bring about pupil dilatation? Remember, the chief action of the oculomotor nerve is miosis or constriction of the pupil, and the opposite action is mydriasis or dilatation of the pupil. Dilatation of the pupil is the function of dilator pupillae, and this dilator pupillae is innervated by sympathetic fibers. Okay, whereas constrictor pupillae is supplied by the oculomotor nerve, and hence it has parasympathetic innervation. So, unopposed dilatation occurs in paralysis of oculomotor nerve or injury to oculomotor nerve. Fine, so that is correct. Then ptosis. Yes, oculomotor nerve palsy results in paralysis of levator palpebrae superioris, whose function is elevation of the upper eyelid and also the superior tarsal muscle. So because of involvement of these two muscles, it results in ptosis. Then abduction. Now let's see if oculomotor nerve paralysis can cause abduction. Unopposed action of lateral rectus can bring about abduction of the eye because the medial rectus is not acting. Okay, so this is also correct. If medial rectus is paralyzed, it cannot bring about the opposite action of lateral rectus, right? So lateral rectus pulls your eyeball laterally or it abducts the eyeball. So even abduction is correct. Now, if oculomotor nerve is paralyzed, can it bring about adduction? No. Why? Because you have the involvement of medial rectus, superior rectus as well as inferior rectus, all of which can bring about adduction of the eyeball, right? So what is the correct option here? The one action which can never occur in oculomotor nerve palsy is the adduction of the eye. Fine. So this is regarding the actions of the oculomotor nerve and what happens when oculomotor nerve is damaged or injured, right? So this is regarding the oculomotor nerve. So once we have learnt about this, let's move on to the next question. The next question was also from the head and neck region and the topic was from the facial nerve, right? Now, what was the question? Paralysis of the muscles of the lower lip. Okay, paralysis of the muscles attached to the lower lip following a parotidectomy. So a parotid surgery is due to injury of which of the following structure? Okay, now there were differences among students when they recalled the options. Some of them said, or some of you said, there was parotid duct as an option. There was trunk of the facial nerve as option. But if the MCQ has to be very tough, they would have given you the branches of the facial nerve because you can easily rule out the parotid duct. Okay, so paralysis of muscles of the lower lip following parotidectomy is due to which of the branch of the facial nerve? So that is possibly the question. Okay, now let's try to recall the anatomy of the facial nerve in the face. As we know, we have the parotid gland and the parotid gland has a superior surface or the base, then it has an anterior border and let's say then it has an apex, right? Now within this you have the trunk of the facial nerve. Fine. Just for understanding, I'll write it in a different color. So what happens is the facial nerve comes out of the stylomastoid foramen and enters the parotid gland, right? Where it is arranged from superficial to deep as the facial nerve, the retromandibular vein, and then we have the termination of external carotid artery. This facial nerve divides into two trunks. What are the two trunks? The two trunks include, so this is trunk of the facial nerve, right? And what is this? This is the temporofacial trunk, right? Because it goes towards the temporal region. And this is called as the cervicofacial trunk. And these further give rise to branches. For example, the temporofacial trunk gives rise to the temporal branch. So this is the temporal branch, and the temporal branch mainly supplies the frontal belly of the occipitofrontalis, the upper half of orbicularis oculi, the occipitofrontalis muscle, all these muscles. Then you have a zygomatic branch. Okay, so this is the zygomatic branch, right? Then it also gives off few buccal branches. Now remember, buccal branches are not single branches, they are multiple branches, and these buccal branches supply majority of the muscles around your cheek and nose. Then the cervicofacial trunk gives off one important nerve which descends into the neck region first and then again ascends upwards. So we call this as the marginal mandibular nerve. Okay, so this is the marginal mandibular nerve. One of the important relation of this nerve you want to remember is when you clench your teeth, you make the anteroinferior angle of the masseter prominent, and at the anteroinferior angle of the masseter, this crosses the facial artery before entering the face. Once it enters the face, this is the nerve that supplies almost all the muscles which are getting inserted to the lower lip. Right? The last branch is the cervical branch, and cervical branch, as we know, supplies one important muscle. And what is that muscle? The platysma. Right? So this is how the branching pattern of facial nerve occurs. So the muscles of the upper lip are basically innervated by the buccal branch, whereas the muscles which are attached to and around the lower lip, these are innervated by the marginal mandibular branch. So during parotidectomy or after parotidectomy, if you have a complication where you see the paralysis of muscles around the lower lip, it signifies the paralysis or injury to which nerve? It is the marginal mandibular branch. And remember, marginal mandibular branch first descends into the neck region and then again ascends upwards, crossing the facial artery at one important landmark, that is the anteroinferior angle of the masseter. So even any incision in this anteroinferior angle of the masseter region can also result in the paralysis of muscles of the lower lip. Fine. So this is regarding the branches of facial nerve and how it affects the muscles of the face. So let's go back and tick the correct option. So what is the correct option here? The correct option here is the marginal mandibular branch of facial nerve. So remember, if parotid duct was given, it's not a correct option because parotid duct carries the saliva, right? It do not innervates the muscles, right? Then when we talk about the buccal branch, zygomatic branch and temporal branch, I told you what muscles they innervate. Okay. Then if trunk of the nerve is involved, it would result in paralysis of all the muscles, right? It would cause the lower motor neuron lesion affecting all the muscles of the face. One half of the face will be affected, right? So here muscles of the lower lip involved because of marginal mandibular branch. Fine. So this is regarding the facial nerve question that was asked. Thank you, Aniket. Hi, sir. Hi, Meenakshi, sir. Welcome. Yes, P for pediatrics. Yes, cervical branch was an option. I think I've not included the cervical branch. If cervical branch was the option, the cervical branch, remember, innervates only platysma. Okay, so that cannot be the option. Again, marginal mandibular branch is again favorite of your examiners because of this reason. It results in characteristic deformity affecting the lower lip, right? So all the muscles of the lower lip are innervated by the marginal mandibular branch. So this was the question regarding facial nerve, right? Hope this concept is clear now. And other concepts you may want to remember: what foramen through which the facial nerve comes out? It is the stylomastoid foramen. And with stylomastoid foramen, one more thing you may want to remember here is one of the important branch of facial nerve is the chorda tympani, right? Now chorda tympani does not come out through the stylomastoid foramen. Instead, it comes out through a fissure called as petrotympanic fissure. Now, why I'm stressing on this is, remember, chorda tympani is responsible for carrying what fibers? It carries the secretomotor fibers to your submandibular and sublingual salivary gland. Apart from this, it also carries the taste sensation. So sometimes this could be a question. Remember, facial nerve and chorda tympani branch of it do not have the same exit. Chorda tympani exits from petrotympanic fissure. Right? So this is regarding the question which was related to facial nerve. Right? Yeah. Hi, Sanjay. So let's move on to the next question. So these were the questions that were there from the head and neck region. And there was one possible question related to the hoarseness of voice during thyroid surgery. What is the possible cause? Splitting of the strap muscles, injury to recurrent laryngeal nerve, then injury to tubercle of Zucker-Kendall, or dissection of Bear strangle. You can just go and watch Dr. Ajay Bhandarkar sir's video. He just described it beautifully. And please wait for Dr. Nishant for his general surgery recall session. He will be taking you through the details of the thyroid surgery, the complication, the anatomy of the Bear strangle and Zucker-Kendall. So I've not encroached on the surgery question. So these will be discussed by Dr. Nishant. And if you want a quick revision, you can go back to the session which was done by Ajay sir and take a look at it. Okay. The other questions, the other favorite topic of examiners, especially when it comes to INICET, is the neuroanatomy questions. And neuroanatomy questions, if you have the concept clear, it is very easy to crack the questions. One of the most common mistake we do in first year is ignore neuroanatomy topics, and this can come back and bite us hard, especially during entrance exam. Fine. If you want your ranking to improve, make sure that your neuroanatomy is strong. Okay. This was one of the image-based question which was recalled by our students. They said this was the question. So let's go through the question to begin with. The marked structure gives origin to which of the following fiber? This may not be the exact question, but this is how most of the students recalled. The section was not the same section. I've taken a reference image. Now, what structure is marked here is the dentate nucleus is marked. Okay. We have 4 deep intracerebellar nuclei, right? So these are dentate nucleus. Then we have the emboliform nucleus. Then we have the fastigious nucleus and the nucleus globose. Right. Doctors eat good food. This is how we remembered, right? So these are the 4 nuclei. So what the question was asking was, what fibers actually come from the dentate nucleus or pass through different parts of the brainstem before it reaches the cortex? Okay. Yes, Aniket. Doctors eat good food. DEGF, the dentate nucleus, emboliform, then you have the globosus and fastigious, right? So from lateral to medial. So what fibers come from dentate nucleus? Remember, dentate nucleus is a part of neocerebellum, right? And when we talk about the connections of the cerebellum, we must be aware of 3 types of peduncles. Okay, so we have 3 peduncles, and these 3 peduncles are the superior cerebellar peduncle, the middle cerebellar peduncle, and the inferior cerebellar peduncle. The superior cerebellar peduncle, remember, connects the cerebellum, right? This connects cerebellum with what? Connects the cerebellum with midbrain, right? Then middle cerebellar peduncle connects the cerebellum with pons. And then inferior cerebellar peduncle connects the cerebellum with medulla oblongata. Right. Now, these peduncles carry both afferent fibers and efferent fibers. But when we talk about the inferior cerebellar peduncle, this is the chief afferent output or chief afferent input of the cerebellum. all the afferents to the cerebellum mostly come through inferior cerebellar peduncle. Whereas the superior cerebellar peduncle is peculiar because this forms the chief efferent output. Okay, so this is the chief efferent output. And where does these efferent fibers go? Remember, these efferents mainly go to the red nucleus, which is located within the midbrain, or they go to thalamus. Right? Apart from this, they also go to reticular nucleus. Fine. Now, red nucleus, as we know, is present in midbrain. So the fibers which come from the dentate nucleus, I told you, when we talk about dentate nucleus, the dentate nucleus is the nucleus of neocerebellum. And what is the function of neocerebellum? This is the cerebellum which controls the coordination of fine movements. Okay, skilled movements. That is brought about by dentate nucleus, and the fibers, they reach the target organ, that is the red nucleus or the thalamus, through dentatorubral fibers, dentatorubral fibers, or if it goes to thalamus, you call it as dentatothalamic fibers. Okay, so these are the chief efferent fibers, remember again, which go to red nucleus in the midbrain or the thalamus in the diencephalon. So what fibers actually come from the dentate nucleus? These fibers go to either red nucleus or they go to thalamus. So let's see if this is one of the option. Fine. If we go through the option, yes, there is the dentatorubral fibers. Okay, this goes to red nucleus, and this is one of the chief efferent pathway of cerebellum, which passes through superior cerebellar peduncle, which connects it to midbrain. Then we have two more important fibers, that is cerebellorubral. Now the confusion here is, here also there is rubral term, right? So is it not the correct option, because the fibers are coming from the cerebellum and going to red nucleus? So this also could be the option, right? So how do you rule out this? Remember, these cerebellorubral fibers come from cerebellum, but mainly from the emboliform nucleus or the nucleus globosus, right? And this or these fibers do not come from the dentate nucleus. So that tells you that cerebellorubral fibers are not the correct option. Then cerebelloreticular fibers, even these arise from the deep cerebellar nuclei, but remember, this mainly arises from the vestigial nucleus. Okay, the cerebellovestibular fibers are mainly present in the inferior cerebellar peduncle as one of the efferent, and these also arise from the vestigial nuclei or the flocculonodular lobe, which is the old cerebellum. Right. So here it is clearly arising from the dentate nucleus. So the fibers arising from the marked region are dentatorubral fibers. Okay, so this is one question that was asked from neuroanatomy, and unless you know the concepts of cerebellar peduncles, connections of the red nucleus, you cannot solve this question. This is why you must have seen a lot of questions in your university exam when you were in first year on red nucleus and medial longitudinal fasciculus, because these are very often asked in your entrance exam. So red nucleus connection, the connections of the substantia nigra, connections of medial longitudinal fasciculus, which coordinates the movement of your extraocular muscles along with the neck. All these are important topics which we often skip in first year, but you cannot do it if you're preparing for your entrance exam. Okay, so this is regarding the first neuroanatomy question that was asked. Let's go to the second question that was asked from the neuroanatomy topic. Now this was related to lateral ventricle. Now again, let's hear that this could be a tricky question. So most of the time what we do, we end up reading about the floor of the fourth ventricle. We keep drawing the rhomboid fossa, trying to identify the structures in the floor of the fourth ventricle, and very often we forget the anatomy of lateral ventricle. Okay, the anatomy of the lateral ventricle is often thought as a very complex anatomy because of its C-shaped structure, but it is not so. Let's see if we can simplify this, the anatomy of the lateral ventricle. Hi sir, hi Devik sir, and hi Akshay sir. So let's talk about the anatomy of the lateral ventricle to solve this question. Let's go through the question first. The question was, which structure, again, remember, is not, negative question, is not present in the floor of inferior horn of lateral ventricle. So you should have gone through this question very carefully. So it talks about the floor, then it talks about floor of the inferior horn of lateral ventricle. Fine. Now, how do we assess the relations of floor of the inferior horn of the lateral ventricle? So what we'll do is, we'll try to simplify this. What I wanted you to take a look at is this cadaveric image where you actually try to locate where exactly is the lateral ventricle. Remember, this is the cavity of lateral ventricle and this is the thin septum pellucidum which closes it off. Okay, and what is this structure? This is your corpus callosum, the largest band of commissural fiber. Now, so if this is the cavity of the lateral ventricle, just take a look at the orientation. This is how the orientation of the lateral ventricle is. Okay, so lateral ventricle basically looks like this and it has one more horn which goes into the occipital lobe. So this is the anterior horn of the lateral ventricle. Then there is body of the lateral ventricle. Then there is posterior horn and then there is inferior horn which goes on to the temporal lobe. So this C-shaped structure is your lateral ventricle. Okay, so if we just draw the outline, so let's imagine this is the inferior horn, this is the body and this is the inferior horn of the lateral ventricle and this is the posterior horn of lateral ventricle. So anterior horn, right? Here what do we have? This is the body, this is the posterior horn and what do we have here? This is the inferior horn which is there in the temporal lobe. Now let's come back to this diagram. Now what you see in this diagram is again the cavity of the lateral ventricle. So this is its anterior horn, this is the region of the body. What you cannot see is the posterior horn and what you cannot see is the inferior horn. Now why this image? Here I want you to identify one important nucleus here. This is the caudate nucleus. So in order to understand the relations of the lateral ventricle, you must know the relation of lateral ventricle to caudate nucleus and corpus callosum, two C's. So let's try to draw the outline of the lateral ventricle. So lateral ventricle has an anterior horn, then it has a body, then it has an inferior horn, right? So this is the inferior horn of lateral ventricle and let's draw the posterior horn. So this is the posterior horn of lateral ventricle. Now what is the relation of corpus callosum? Just observe, the corpus callosum genu covers the anterior horn and forms the floor of its anterior horn. So this is the anterior horn and this is the body, posterior horn and this is the inferior horn. Okay, so you have the corpus callosum, the splenium forms the floor of the anterior horn, then the genu forms the anterior wall of the anterior horn and then forms the roof. Right, see, it is not that difficult. You might go through complex diagrams and think that this is difficult, but here all you need to remember is all the boundaries of the anterior horn are formed by corpus callosum, different parts. That's it. Okay, so corpus callosum continues on the body, right? And then it forms what we call as splenium. So this is the body and let's say this is the splenium of corpus callosum. Once you know this, one more thing you must know here is the caudate nucleus. Okay, so let's imagine we have the caudate nucleus body, the head of the caudate nucleus, and then let's say this is the body and tail of the caudate nucleus. Now, if you have to relate the caudate nucleus and what is this? This is corpus callosum. If I ask you what structure forms roof of the body of lateral ventricle, what will be your answer? It is the body of corpus callosum. If my question is what structure forms the floor of the body of the lateral ventricle, then your answer is body of the caudate nucleus. If my question is What forms the roof of anterior horn? It is corpus callosum, the body. What forms the anterior wall of the anterior horn? It is the geno of the corpus callosum. What forms the floor of the anterior horn? Your answer is the rostrum of the corpus callosum along with head of the caudate nucleus. Similarly, why you are asked this question is the examiner wants to test you whether you know the relation of the caudate nucleus with the lateral ventricle. So if you complete the outline of the entire brain, okay, so let's imagine we'll draw the outline of the brain here. Okay, let's talk, this is, we are talking about the medial surface and this is the temporal lobe. Fine. So the relations of the inferior horn are, at the roof, it is related to tail of the caudate nucleus, whereas in this region, it is related to two important structure. So one important sulcus and one important part of the limbic system. What are these? These are your hippocampus. Okay, one is the hippocampus region and this region is the collateral eminence. Now, what is collateral eminence? Collateral eminence is a projection in the inferior horn of the lateral ventricle produced by collateral sulcus. Remember, if you have watched our main videos, okay, the main videos of neuroanatomy, we have discussed about the types of sulci. One of the most important type of sulci is complete sulci. Complete sulci produce indentation within the lumen of the ventricles. And one of the most important complete sulci you will ever come across is the collateral sulcus, which produces collateral eminence within the inferior horn of lateral ventricle. Fine. So this is not only testing the relations of the lateral ventricle, but it is also testing your knowledge of the classification of the sulci, the location of the hippocampus, the location of the caudate nucleus and its relation to inferior horn. Right? So this is why the lateral ventricle anatomy and its relations are very important. Okay. Now that is what I wanted to show you in this image. Okay. So this is the caudate nucleus and head of the caudate nucleus, body of the caudate nucleus and then the tail of the caudate nucleus. So the tail of the caudate nucleus forms what structure? The roof of inferior horn of lateral ventricle, whereas the floor has hippocampus and collateral eminence. So once we have learned the relations of the lateral ventricle, let's see if we can solve this question. Okay. So first, now, is collateral eminence related to the floor of the lateral ventricle, inferior horn? Yes. If hippocampus is related, yes. Tail of the caudate nucleus is a definite no. But then we have the choroid plexus. Now what about choroid plexus? Remember, the choroid plexus is present close to the floor of the inferior horn. The choroid plexus is responsible for secretion of CSF. Right? So even that is present in the inferior horn. So what structure is never forming the relation of the floor? It is the tail of the caudate nucleus. Why? Because this is related to the roof of the inferior horn of lateral ventricle. Right? Now hope this is clear. So imagine if you learn the anatomy of the lateral ventricle like this, it becomes a lot more easier. Of course, learning it through coronal section, I believe is a little bit complex, but you have to learn lateral ventricle relation by drawing the outline of corpus callosum, by drawing the outline of the caudate nucleus, so the concepts become a lot clear. Okay, now hope this is clear. One more thing about ventricles is always know about communication. How lateral ventricle communicates with third ventricle, how third ventricle communicates with the fourth ventricle, the interventricular foramen of Monro and the cerebral aqueduct. Okay, so the pathway of CSF flow is also a must-know topic for your entrance exam. Right, so this is regarding the two questions that you could recall from neuroanatomy. Right, then there was one question which was related to the anatomy of pelvis. Yeah, good evening, Dr. Raj. So one question was from the anatomy of pelvis. Now again, this was a tricky question. Now let's see if we can solve this. Right? Now the question goes like this: at which vertebral level? So remember, here they are asking about vertebral level. So one more important topic that we often neglect as students is the surface marking, the surface anatomy, because like it's there for 5 marks in first year, so let's forget it, let's not worry about it. Know the surface marking of McBurney's point or kidney or Morris parallelogram and we can get through. But remember, surface marking carries a lot of importance when it comes to examination of clinical systems. Unless you know the skeletal landmarks and soft tissue landmarks, examining the organs or defining the region is impossible. Okay, so what question was asked? At which vertebral level is the pointed structure located? Most of you said this was an image based question and the structure marked was. So let's try to identify what structure is marked. The structure that is marked looks to be the ischial spine. Right. So at what vertebral level does ischial spine lie? Now this is a tricky question, as I told you, because most of us would have not gone through the level of ischial spine. But again, how to solve this question? Let's try to understand. So he has given L4, then L4 and L5, then S3 and then tip of the coccyx. Okay. Now remember, MCQs are about finding the most appropriate response or the best response. It is not always about choosing the correct response, right? So let's try to solve this question. Okay. Now, couple of things that you must understand before solving this question is, can you tell me what is this structure? Okay. Now, this is the section, the sagittal section of the entire abdomen, and you are seeing the pubic symphysis, and here you are seeing the sacrum and the coccyx. Fine. Now, one thumb rule with respect to the tip of the coccyx is, the tip of the coccyx and the pubic symphysis, they lie in the same horizontal plane. This is the first thing that we need to understand. Remember, your pelvis is not present like a basin. Instead, it is tilted forwards. Tilted forward so that the anterior superior iliac spine, which lies here, and the pubic symphysis are in the same plane. Okay, so your pelvis is tilted, not like this. Okay, you cannot hold it like a basin. That's what I'm telling. You need to tilt it so that the anterior superior iliac spine and the upper margin of pubic symphysis are in the same plane. How we would do this? You keep a sheet of paper, make sure that the anterior superior iliac spine and the pubic symphysis both touch the paper. Take out the paper, that gives you the anatomical position of the bony pelvis. Right. Now, one more thing I want you to remember here, as I said, the pubic symphysis and the tip of the coccyx, they lie in the same plane. Right. So, if here you have the tip of the coccyx, here you have the upper margin of pubic symphysis, they are lying in the same plane. And the same holds good for this ischial spine. So, if you connect ischial spine, it passes through the tip of the coccyx and also passes through the same level as that of the upper margin of pubic symphysis. Okay, so this is regarding how to solve this question. Okay, so ischial spine, how they are related? They are related to the pubic symphysis and the tip of the coccyx because all of them lie in the same plane. Fine, this is how you remember it. Okay, so if you want to solve this question now, remember L4, L5 level is the space where you actually perform the lumbar puncture or the spinal tap, right? Because your spinal cord ends at the level of L1. So usually you prefer the space between L3 or L4 or L4 and L5, right? Then S3 is not a correct option for any of the planes. Why do I say this? Because if you just enlarge this image, so this is the anterior superior iliac spine, and then here we have the highest point of the tubercle of the iliac crest. Okay, now we have a plane called as supracrystal plane. Okay, this supracrystal plane or Taffier's line passes through L4 and L5. Okay, so that is the highest point of the iliac crest. So the highest point of the iliac crest passes between L4 and L5, the plane. Now this plane is what they have asked. Then we have S2 level, not S3. But S2 is the level where you have the posterior inferior iliac spine. So similar to anterior superior iliac spine, you have the posterior inferior iliac spine, and these pass through the S2 level. So don't get confused there. So the ultimate level that we are left with is the tip of the coccyx. Remember, tip of the coccyx, pubic symphysis and ischial spine, all of them lie at the same plane. Okay. Hi ma'am. So this is regarding one of the question that was asked on surface marking on vertebral levels of the ischial spine. Now hope this is clear, right? Then the other question was from the transverse section of the abdomen. I believe this was also an image based question. Now what you can actually see is a cadaveric image. Okay, this is not a schematic representation. This is a cadaveric image. So what was asked, at which vertebral level was this section taken? Again, you have the vertebral level given. Now the trick is to identify what section is this and at what vertebral level this has been taken. Again, a lot of students said that this section was from T10 level, the esophagus was seen, and some of them said esophagus were never seen, the sections of the lungs were not seen, so possibly this could be T12 section. So what I've done is I've taken the section at T12 level and I'll try to explain how to differentiate between the sections of the abdomen at various levels. Fine. Now for this, let's try to compare these two images. Now these are the images of the transverse section of the abdomen. Now this is taken at the level of T12 and this is taken at the level of L1. Now how I would say that this is from T12 and this is from L1. Now first let's enlarge this and try to identify the structures. Okay. Now if you identify the structures to begin with, so first let's say this is the vertebra. Okay, let's say this is the T12 vertebra. And here you have the position of the xiphoid process. Okay, the anterior thoracic wall. And you can even see the cut section of the ribs. Right. Now, what is this? This is the liver. Section of the liver that we know. What is this? This is stomach. Right. Now, what is this? This is the inferior vena cava. And what is this? This is the abdominal aorta. Okay. And what is this? This is the section of the spleen. And what is this? This is your diaphragm. Okay. So at the level of T12 vertebra, you will not see esophagus. Why? Because esophagus passes through the esophageal opening which is located at the T10 level and there it continues as the cardiac end of the stomach. So that is one explanation why that this is not a section taken at T10 level. So if it was taken at T10 level, you would have seen an additional structure here and the structure would have been esophagus. Okay, so since esophagus is not seen, this is a section taken at T12 level. Now, remember, lungs are not seen, but the section of spleen is seen here. Just compare this with the section taken slightly below at the level of L1. Now, why do I say that? This is the section taken at the level of L1 vertebra. Remember, L1 vertebra also signifies the transpyloric plane. That is plane passing through the pylorus of the stomach. Anteriorly, it passes through the tip of the 9th costal cartilage or fundus of the gallbladder, and posteriorly, it passes through the lower border of L1. So let's take this as the lower border of L1. This is the section of liver again. You can even see falciform ligament here. Then you can see the stomach, the lowermost portion of the pyloric part. Here you can see the duodenum. Here you can see the coils of jejunum and ileum, right? Then what are these structures? What are these structures which are seen at the level of L1? Remember, these are possibly the section of the left kidney and here you have the right kidney. Done, the upper pole of the right kidney, and then we have the hilum of the left kidney because the hilum of the left kidney is at the level of L1. Okay, so this is L1 level possibly, right? Now, apart from this, what are the other structures? Here you have the gallbladder, the fundus of the gallbladder. Here there is the inferior vena cava. Now here you have the abdominal aorta. This is the portal vein. Remember, portal vein is formed just behind the neck of the pancreas. So here there is pancreas. So we have the portal vein. And what is this? This is superior mesenteric artery, and this is your abdominal aorta, giving rise to the superior mesenteric artery, the second ventral branch. So if you see the section of kidney and the hilum, possibly the section is taken at the level of L1. Fine. So this is how we can actually tell which section the transverse section has been taken. Okay. If they give cadaveric image, it is a lot more easier. If they give schematic diagram or colored images, look for the kidneys to tell whether it is L1 level or not. Look for the superior mesenteric artery which arises from there. Basically, what you need to do is you need to remember all the events that occur at the level of the transpyloric plane. Yeah. Good evening, Dr. Reshma. So this is regarding the transverse section of the abdomen. So this was the question asked. So I would go with the possibility of the sections given, the level at which is given. So I would go with T12. Okay. If you had not seen esophagus, if you see esophagus and sections of lung somewhere here, okay, and only part of the spleen, I would go for T10. But looking at this section, I would definitely go for T12 considering all the options given. Right. So this is regarding the transverse section, and remember, sectional anatomy becomes very important if you want to identify the CT images or the MRI images. Okay. So this is regarding the transverse section of the abdomen. Right. Now let's move on to the last few questions. So one was with respect to the arterial supply of the heart. Now, in the arterial supply of the heart, again, one of the favorite topic of your examiners, let it be your university exam or entrance exam, what was asked was which artery supplies the pointed structure. Now let's see what is the pointed structure. So this is the pointed structure. Now imagine if you have to identify this in your entrance exam within 1 minute, where you have to take a look at the image, identify the structure. So this is where your identification skills will come very handy. Okay. Now this is a section of ventricles of the heart. You can see the outlet arising from the left ventricle. You can see the valves. You can see the chordae tendineae. You can see the papillary muscle. Now, what you need to identify is what is this region? This is the region of interventricular septum. Okay. Now, the question was which artery supplies the pointed structure? Okay. So, interventricular septum is what we know. Now, try to recall your knowledge of which artery mainly supplies the interventricular septum. Interventricular septum is mainly supplied by two arteries. One is the left anterior descending artery, LAD, or interventricular artery, anterior interventricular artery, and posterior interventricular artery. Both of they supply the interventricular septum. But remember, majority of the interventricular septum, especially in its anterior 2/3, is by the left anterior descending artery or the anterior interventricular artery. So let's see if that is there in the option. Okay. So if we look at the option, we have the left anterior descending artery definitely. Okay. So this is the correct option. So let's see other options. You have posterior interventricular artery also. But remember, posterior interventricular artery supplies the posterior inferior part, posterior inferior 1/3 of the interventricular septum. So the major artery that supplies the interventricular septum is the left anterior descending artery. Okay. Then the left marginal and right marginal artery, they do not supply the interventricular septum. Instead, they mainly supply the ventricles on their sternocostal surface or the diaphragmatic surface or the left surface. Okay. Now, let's try to summarize the arterial supply of the heart. Here what we have is, we have the branches coming from the right coronary artery. Okay. So let's try to understand the branches coming from right coronary artery. The first branch which comes from it, which supplies the ventricle, is the right conus artery, and this supplies the infundibulum of the right ventricle, and sometimes this is called as the third coronary artery. Okay. So we call this as the third coronary artery. Then we have the right anterior ventricular rami, which supplies the right ventricle. Okay, the sternocostal surface mainly. Then we have the atrial rami, which supplies the right atrium. Okay, then this atrial branch also gives off the SAN artery. So this supplies the sinoatrial node. Now this is one more favorite topic of your examiners. The sinoatrial node is supplied by the right coronary artery through its atrial rami. Then it gives off right posterior ventricular rami, which will supply the posterior surface, or to be more specific, this supplies the right ventricle. So we'll use a different color. So it supplies the right ventricle, especially its inferior surface or diaphragmatic surface. Okay. Then posterior interventricular artery supplies the posterior inferior part of the interventricular septum. Okay. This supplies the posterior inferior part of posterior interventricular septum, and this is the one which gives rise to coronary dominance. So if the posterior interventricular artery is a branch of the right coronary artery, we call it as right coronary dominance, which is more common. If it arises from left, you call it as left coronary dominance, which is less common. Then right posterior atrial rami again supplies the posterior part of the right atrium. So if you summarize the arterial supply of the right atrium, it mainly supplies the entire right atrium, the right coronary artery. Then it supplies the sternocostal surface and the diaphragmatic surface of the right ventricle. It also supplies the posterior inferior 1/3 of the interventricular septum. Whereas the major supply of the interventricular septum is from the left coronary artery. Okay, the left coronary artery gives off the left anterior descending artery, also called as anterior interventricular artery, which gives off two branches. Anterior ventricular rami, which will supply the anterior surface of left ventricle. Okay, sternocostal surface of left ventricle. Then it gives rise to septal rami, and this is possibly the most important branch because this supplies the anterior superior 1/3 of the interventricular septum. And this is one of the chief arterial supply of the interventricular septum. Apart from this, remember, we have the circumflex artery. So there are two major arteries, left anterior descending and circumflex artery. These are the two major branches coming from the left coronary artery. Okay, the left coronary artery circumflex branch gives off atrial rami, which supplies what? The left atrium. Ventricular rami, which supplies the left ventricle, especially the left surface. The SAN artery arises rarely in about 20 to 30% of the individuals from the circumflex artery. The left marginal artery again supplies the left surface of the left ventricle. The posterior interventricular artery again is rare, seen in only 30% of the individuals. In majority of the 60 to 65% of the individuals, it arises from the right coronary artery. Then we have the Kugel's artery, which is the atrial branch coming from the left coronary artery. Sometimes this supplies the sinoatrial node. Okay, so arterial supply of the heart and its venous drainage. Okay, these are two topics which are a must-know topic for your entrance exam. Fine. So this is regarding the summary of the arterial supply of the heart. There was one more question which was from the thorax region. Of course, this was from the chest X-ray. I need to apologize to Abhishek sir because I've stolen this question from him. Chest X-ray again is like one of the X-rays that are like very often asked as a first year medical student if you are going to your practical exam. Okay, so this is one X-ray that you can never ignore. You have to learn the basics of how to interpret the chest X-ray, right? So one question was from the plain X-ray of the chest. Now, which structure is pointed by the arrow? So I have gone by what most of you have said, what structure was marked. So let's try to enlarge this and see what structure is marked. So the structure marked appears to be a rib. So is rib a option? Yes. So anterior part of the rib and posterior part of the rib. There is also intercostal space. There is costal cartilage. costal cartilage is ruled out because unless they are calcified, you cannot identify costal cartilages. So this option is ruled out. So we need to check whether it is anterior part of the rib, posterior part of the rib, or the intercostal space. Now we can easily identify the intercostal space as these dark black areas. Okay, where you have the lung field, so that is why they are appearing as the dark areas. Now remember, they have marked the rib, so we are sure that this is a rib. Now which part of the rib is the question. Now how to identify whether it is the anterior part of the rib or posterior part of the rib. So if you take an enlarged view of the chest x-ray, forget about that ABCD now. So we will concentrate only on the bones, how to identify the posterior part of the rib and anterior part of the rib. So what x-rays are usually taken with respect to chest? Most often they are the posterior-anterior view. They are PA view, so that you can see the mediastinal shadow and the heart shadow clearly along with the lung fields. Now the posterior part of the ribs, remember, are comparatively prominent and they have a more straight course or longitudinal course compared to the anterior part of the ribs. So just see here, this is the outline of the anterior part of the rib. This is the outline of the anterior part of the first rib. So anterior part of the rib, they are very faintly seen and they never reach the midline. Whereas if you trace the posterior part of the ribs, they always begin from the vertebral column because of the articulation of the head with the vertebral body, right? So this is the posterior part of the rib, which begins from the vertebral column and runs a more horizontal course, whereas the anterior part of the rib, they run an oblique course and they never reach the vertebral column or the sternal shadow. This is how you differentiate between the anterior part of the rib and posterior part of the rib. Okay, anterior part of the rib, remember, fall short of the vertebral column because the costal cartilage attached to the sternum, and costal cartilages, unless they are calcified, they cannot be seen in X-ray. Okay, so the correct option here would be what? Would be anterior part of, it is the posterior part of the rib. If you tell it as the anterior part, how to tell whether it is anterior part? Remember, if they had marked this portion of the rib, right, that would have been the anterior part. Okay, since we see the horizontal part which is coming from the vertebral column, we can confidently say that this is the posterior part of the rib. Okay, so the correct option here is the posterior part of the rib. So this is how we identify the parts of the ribs on a plain X-ray of the chest, right? Now these were the questions from the X-ray. Okay, now one last question from the thorax, which was again based on a bone, and that was a vertebra. Okay, now the vertebra that is given is a thoracic vertebra. Now how do I say that this is a thoracic vertebra? Take a look at this part. Okay, now this is the most conspicuous feature of a thoracic vertebra. Now what is this? This is a costal facet. So this costal facet is for articulation with the rib. So to call it as a thoracic vertebra, it should have what? It should always have a costal facet. Okay, so this is the costal facet. This is the articular process, the superior articular process. This is the spinous process. So here we have the transverse process and here we have the body of the thoracic vertebra. What are the joints formed by a typical thoracic vertebra? Remember, a typical thoracic vertebra will articulate with one more vertebra above. Okay, and this joint is a symphysis or secondary cartilaginous joint. So intervertebral disc which connect the two vertebral bodies are example for the symphysis or secondary cartilaginous joint. Then when we talk about the costal facet, okay, the costal facet or the facets on the transverse process or even these joints which are formed by the articular processes or zygapophyseal joints. So all these are example for plain synovial joints. Okay, so plain synovial joints are also formed by vertebra at where they articulate with the ribs. either at the body or at the transverse process, and of course the articulation between the articular processes. Then what was there in the other option? So symphysis is ruled out, then plain synovial is ruled out, and then we have syndesmosis and synchondrosis. What do you mean by syndesmosis? Remember, syndesmosis is the fibrous joint. Okay, it's an example for fibrous joint where two bones are articulated with the help of ligament or membrane. Now remember, there are a lot of membrane that extends between the different parts of the vertebra, especially the lamina of the vertebra. So individual vertebrae are also connected by these membranes. So the vertebra will always have even syndesmosis or fibrous joint. What is not present is the synchondrosis. Synchondrosis is the primary cartilaginous joint which is basically seen between the epiphysis and the metaphysis. Okay, so this is primarily seen in growing bones. Okay, so synchondrosis is never seen as a joint formed by a vertebra. Okay, so this is regarding the joints formed by vertebra. So remember, vertebrae forms a fibrous joint, then it forms a cartilaginous joint, but it's a secondary cartilaginous joint, the intervertebral disc, that is the example for symphysis. And of course, the last option was plain synovial, the articulation between the ribs and the vertebra, the articulation between the articular processes, all of these are plain synovial joint. So what is not seen is the synchondrosis, which is a primary cartilaginous joint. Okay, so this was related to osteology of thorax. So there were three questions which were related to anatomy of the thorax, not directly. One was a chest x-ray, and of course one was the vertebra, right? So these were the questions that were asked in your recent INICET exam, which were from anatomy. I might have missed few questions because I took these questions as the recall questions from most of our students. Hope I have covered almost all questions that were asked. If I have left out any questions, please reach out to us. We would like to discuss and share the video with you. I thank you all for joining this session. Thanks again. Hope the session was useful. Good night.